Thank you very much for allowing me to giving me the opportunity to come and speak at the World Congress of Internal Medicine. I'm Paul Marasco. I'm an associate professor in biomedical engineering at Cleveland Clinic. I actually work, so I was asked to talk about robotics in medicine, and I work in robotics, I work in advanced bionics, but I work in sensory neural machine interfaces, so communicating with the nervous system and providing feedback for devices. So I'm going to take this in just a little bit of a different direction, because we're typically used to talking about robotics in medicine with respect to surgical robotics or companion robotics for recovery. I'm going to walk down a new path for the use of sensory neural bionics, actually as almost a treatment paradigm. So as I mentioned, hang on here. There we are. So my disclosures. So I'm a lead inventor on the technologies that we're going to discuss. So here we are. So what I work in is, as I mentioned, sensory integration for prosthetic limbs. So actually we work in a model system where we rewire amputees, take the nerves that are left after the amputation and then rewire them to new skin and muscle sites. And essentially we use these advanced systems to provide a sense of movement, a sense of intuitive movement, a sense of touch from the devices, and then also the feeling of movement itself. So when they intend to make a movement, they feel that same movement. And here's what this looks like. So you'll notice this is one of our amputee participants. Give me just a second for the video. Yeah, I love that I work in advanced neural machine interfaces at cognitive bionics, and the most difficult part of my job is getting videos to run in PowerPoint. So here we are. So what I'm doing is I'm reaching over. This is Claudia. You'll notice that we're kind of bored. She's sitting there. I reach over with my hand and I touch her fingertips. And when I touch her fingertips, Claudia actually reacts to that. Her brain actually perceives the touch that I'm providing to her fingertips as occurring in her own hand. Okay. So as I mentioned earlier, we also work in the sense of limb movement, and kinesthesia, which is your sense of how your joints are moving through space, is actually a sense that most people don't even know they have. What we do is we use these cognitive bionics to actually hack into people's perceptual integration systems. So what we do is we use a robotic system to generate complex percepts of individual grip movements, like cylinder grip, fine pinch, flat pinch. And these are all perceived as actually coming from the prosthesis itself. And this is what this looks like, and we may just skip the video. And while this is preparing to load, what you'll see, this is Amanda. She's also one of our participants. So Amanda's actually being provided with the sense of limb movement. She's thinking, I'm going to close her hand, or she's going to close her hand. The computer system is reading the signal that Amanda's brain's generating to close her hand, and then it's telling the hand to close. And what she's showing us with her right hand is the actual sensation that she's feeling, and she can't feel the movement or see the movement of the hand as it closes. And we'll go ahead and just skip that too. All right, so what we do, when we actually put all these bionic systems together, we run them in essentially a fully integrated neurorobotic system that communicates simultaneously. So all of the different modalities of movement, intentional movement, the touch from the fingertips themselves, and then the sensation of the movement itself is all essentially coalesced and brought together as an integrated whole. And so they feel the device, they think about moving it, they feel it, and they feel the touch from the hands all simultaneously. And so what this leads to is this kind of this question of cognitive robotics. And this is the field that we work in. And we use sensation as a way to get into the neural system to actually interact with cognition and perception. And when we turn these devices on, this is a very interesting thing, we actually establish a cooperative relationship between the device, the human, and the device itself. And so we actually ourselves, we collaborate and cooperate with our bodies, and most of the functions of your body are actually autonomous. And we're fooled into believing that we have control over them because it provides us with the right sensation and feedback so that we interpret these relatively autonomous movements that your fingers engage in and your feet engage in when you walk. We interpret those as actually being a part of us. And so we say, all right, well, here's the system. It's doing what I expect it to do. And I'm just going to go ahead and hand over the keys. I'm going to let it do what it needs to do, and I'm going to attend to different things. And an interesting piece of this technology is the idea that this cooperative relationship, one, we cooperate with our bodies, but we also can cooperate with advanced machines, both bionics and, as we mentioned, as we learned earlier about artificial intelligences, these are actually autonomous machines with intent that have an understanding of the position and the place that we are as people in the world. And then whereas we're working on approaches to actually help us with these devices much more effectively. And so what we do with our approaches in advanced bionics is, as I mentioned earlier, we hack into people's perceptual integration system. And so we get into the system that your brain uses to establish whether or not you are the person who's making the movements that you're making, or you are the person that is actually feeling the touch that you're feeling. And so what we do is, with an understanding of how the brain's actually processing this information and how these brain circuits actually work, we've started developing robotic systems that engage with these brain systems that aren't necessarily associated with prosthetics. So we've learned a tremendous amount about how our brains communicate with devices. And now what we can do is say, hey, now we can get into these circuits, we can provide information from a robotics perspective, but then we can do some very different things. And one of the technologies that we're working on right now is this cognitive robotics technology for pain, what we call the needle buddy. And needle pain, injection pain is one of the strongest predictors for post-injection flare pain. Similarly, injection pain is the strongest predictor of anxiety and needle phobias. And needle phobia is people not wanting to actually engage with a needle it's a pretty large problem. 10% of patients will actually completely forego any kind of clinical care because they want to avoid engaging with a needle. About 30% of the population actually has a significant needle phobia itself. And so, you know, so one, from the perspective of helping people to avoid pain, one of the things that we'd like to try and accomplish with the technology is actually also interrupting the phobias earlier before they actually fully form as children. So using devices to actually provide people to dampen the phobias. And then the other thing is that when we're working in situations, you know, phlebotomy is relatively straightforward. Some of the other procedures are relatively straightforward. But one of the difficult places for injections is any kind of injection into the hand joints. Individuals who are having surgeries or having injections into their joints for steroids, this is a significantly painful procedure, and you can't really provide any anesthetic help because you're actually putting a needle in to put in anesthetic. And so you're kind of stuck. You sort of have to ride this injection out. And so what we have is a robotic system that then there's no injections, there's no anesthetics, there's nothing. It's actually a cognitive system that we use, where we put your hand in, and based on our advanced bionics, we actually trade what you believe to be your hand for another hand, which makes your brain cognitively disassociate from your hand as the needle's being put in. It's not a distraction. We're actually getting into the cognitive network itself and turning it off. We put you into a state of cognitive neglect. It takes about a minute. Your hand slides right in, you put the person in the machine, turn it on, goes for a minute, and then we get a 30-point reduction on the visual analog scale for pain over standard of care. And standard of care is going to be injection with a vibration device, which is essentially one of the clinical devices called the Buzzy, or there's just the straight injection with no numbing agents on the skin. Another interesting thing is we actually get a 13-point reduction from a non-needle procedure as well. And this is an interesting thing because we're not actually doing anything other than showing a person how we're showing a person an analog of the limb, we're touching in a particular way, their brain's accepting of this robotic system as being a part of their body, cognitively neglects their own body, and reduces their sense of pain. So one of the other interesting things that we use with this device, we're working at cognitive robotics and epilepsy as well. And the device itself, the approach is simple. It's your brain establishes that you are a person, that your arms and your legs belong to each other just by virtue of the idea that when you see what you feel and matches up, when what you see matches with what you feel, your brain says, okay, well, this is me. But those circuits seem like they can actually become broken. In situations with epilepsy, these brain networks seem to lose their hold on context. And we think that there's actually implications about how the brain's processing information from an epileptic perspective. And we found with this device, we can actually tell when individuals are on their medication versus off their medication. Their brain becomes more permissive to allowing just simple correlations to come through. The fingers can be mixed up, the hands can be tapped in different ways, and the brain says, that's still good enough for me. And we think that this is a part of one of the root causes of some different types of epilepsies, that it's allowing these non-contextual information to propagate within the network itself. And then one of the other technologies that we're using is our bionics actually amplify information. In stroke, this is an individual with a sensory stroke. Their motor system's actually intact and they've lost the sensation of movement. And it doesn't look like this one's gonna run either. Oh, here we go, first video to run. Excellent. So this is an interesting video because this individual, their motor system's completely intact. They've actually had a stroke in their sensory system, in their system for movement perception, or kinesthesia. And you notice that their grip and their grasp and their ability to touch objects is significantly impaired. And what we're working on now is actually, as I mentioned earlier, really understanding these brain circuits of how movement sensations actually operating. And we work in an epilepsy center at Cleveland Clinic where we're getting a sense of we're actually tapping into these systems and getting a sense of how they're operating. And with a little understanding of how these systems are working, what we're able to do is actually provide kinesthetic information in people with stroke, just as we would with our amputees with a neural machine interface. And we're essentially telling the brain, these are the movements that you're making. And when the brain loses its ability to understand its own movements, it stops being able to move appropriately. And when we provide that sensation back, we're actually instantaneously in a stroke model, we're actually able to increase lengthen reaching trajectories. We can actually increase elbow joint angles. We smooth out the movement. The neat thing about it is it's not a learned process. These are all essentially happen online instantaneously because the brain gets the information that it needs that's appropriate and tells it tells it that it did what it intended to do. All right, and with that, I'll go ahead and turn it over to our next speaker.